Hi and welcome to Crack the Board. In today's video, we will have a look at questions related to pathology. Let's have a look at the first question. A 30-year-old woman presents to her physician with swelling in her neck. She has no significant past medical history or family history, and her vital signs are normal. On examination, the cervical lymph nodes in the right anterior cervical triangle are enlarged, firm, non-tender, and discrete with no evidence of organomegaly or other lymphadenopathy. A chest radiograph reveals a widened mediastinum, and immunotyping of the tumor cells show positivity for CD15 and CD30. A biopsy of an affected lymph node is performed. What is the most likely diagnosis? A. Burkitt lymphoma. B. Follicular B-cell lymphoma. C. Hodgkin lymphoma. D. Reactive lymphadenitis. The correct answer is C. Hodgkin lymphoma. This is because in the image shown below, we can see Reed-Sternberg cells, which are characteristic of Hodgkin lymphoma. Now, Hodgkin lymphoma is a malignancy of lymphoid tissue characterized by the presence of Reed-Sternberg cells, which are pathognomonic for this disease. These cells are large, multinucleated, and have prominent nucleoli, giving them a classic owl eye appearance. And the patient's biopsy confirms the presence of Reed-Sternberg cells, which also test positive for CD15 and CD30. These are the markers that are highly specific for Hodgkin lymphoma. Let's have a look at why the other options are incorrect. Now, A, Burkitt lymphoma is incorrect because Burkitt lymphoma is a non-Hodgkin lymphoma and it's associated with Epstein-Barr virus and C-Myc translocation. It is characterized by diffuse infiltrate of small, round B lymphocytes interspersed with pale staining macrophages and apoptic bodies, giving it a starry sky appearance as shown in the image here provided, and there is no Reed-Sternberg cells seen. Option B is incorrect because follicular B-cell lymphoma is also another type of non-Hodgkin lymphoma. It originates from the germinal B cell and is characterized by small cleaved neoplastic cells as shown in the image provided, and also there is absence of Reed-Sternberg cells. Option D is incorrect because reactive lymphadenitis is a benign condition caused by infection or inflammation. It is typically associated with painful lymph nodes and shows hyperplasia of immune cells, such as B cells, T lymphocyte, histiocyte, or a combination of these, depending on what the actual etiology is. This patient's painless firm lymphadenopathy suggests a malignant cause rather than a reactive process. Let's have a look at the second question. A 60-year-old man with a history of recurrent tonsillitis during his youth and long-standing atrial fibrillation presented with chronic fatigue, orthopnea, and recurrent episodes of pulmonary edema. He frequently produced rust-colored sputum during these episodes. Echocardiography revealed significant left atrial dilatation secondary to a mitral valve abnormality. Despite medical management, the patient eventually died due to complications from advanced heart failure. The accompanying image displays the opened left atrium and the mitral valve. What is the most likely cause of this valve lesion? A. acute bacterial endocarditis, B. chronic ischemic heart disease, C. chronic recurrent rheumatic fever, D. mitral valve prolapse, E. systemic lupus erythematosus. The correct answer is C. chronic recurrent rheumatic fever. It is very evident from the picture provided that this patient had mitral valve stenosis because the valve had become thickened, fibrotic, and calcified. This condition most commonly is caused by chronic recurrent rheumatic fever following an infection with group A streptococcus. Because the valve is stenotic, blood flow from the left atrium to the left ventricle becomes obstructed, causing the blood to accumulate in the left atrium. Over time, this leads to left atrial dilatation, which predisposes the patient to chronic atrial fibrillation. Additionally, the backflow of pressure into the pulmonary veins raises capillary hydrostatic pressure, leading to pulmonary edema and hemorrhage. This explains why the patient coughed up rusty-colored sputum, a classic sign of red blood cell leakage into the alveoli due to high pulmonary pressure. Let's have a look at why the other options are incorrect. Option A is incorrect because acute bacterial endocarditis caused by pathogens such as Staphylococcus aureus primarily result in mitral regurgitation and not mitral stenosis. This is because the infection damages the valve acutely, leading to leaflet perforation and loss of structural integrity, which causes the regurgitation. Option B is incorrect because chronic ischemic heart disease can cause left ventricular dysfunction, leading to stretching of the mitral valve ring and mitral regurgitation. However, it does not lead to the fibrotic narrowing characteristic of mitral stenosis. Option D is incorrect because mitral valve prolapse is primarily associated with mitral regurgitation. In mitral valve prolapse, the valve leaflets bulge into the left atrium during systole, and there is no pathological narrowing of the valve. Option E is incorrect because SLE can cause Lippmann-Sachs endocarditis, a condition where sterile vegetations form on the mitral valve. While this can lead to mitral regurgitation, it is not associated with mitral stenosis. Furthermore, Lippmann-Sachs lesions do not cause the degree of fibrosis and calcifications seen in rheumatic mitral stenosis. This concludes today's set of questions. If you liked this video, please make sure to click the subscribe and the like button to support the channel.